Everybody, and welcome to our CMR conference series that's weekly here at VCU. Very pleased to be joined by Dr. Leila Rezai Gharai, who is going to be presenting today on coronary artery assessment with CMR and how that differs from things like CT. Really great topic. We've been sort of missing this in the conference, so I think this is going to be a really nice talk. And don't forget, everybody, that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided. And for any MRI technologists in the audience, Shannon, can you confirm this one's ASRT accredited?
Yes.
I believe the answer is, oh, Shannon, you're muted.
Yeah, sorry, I thought I went off mute. Yes, it's ASRT as well.
Okay, so yes, ASRT accredited. Make sure any MRI technologists are sort of individually logged in so we can track attendance, and then also don't forget to log your attendance. And with that, I'll go ahead and hand it over to Dr. Rezai. Thanks again.
Sure. Thanks for introduction. Good morning, everybody. So for some time, I was hoping to be able to give this lecture. This is looking at coronaries from a different perspective. And the reason I came up with this idea was that when we talk about coronary arteries, we immediately talk about atherosclerotic disease, obstructive disease, ischemic disease, and the role of MRI is more focused on the stress MR. However, there are other aspects to coronary arteries, including anatomy, diseases such as vasculitis and infiltrative diseases, aneurysm, and relationship to cardiac masses. With that, I start talking about anomalous coronary arteries. It's just going to be a very light touch on this topic, and then we move on with imaging and how we can utilize cardiac MRI. Overall incidence is 5.6% of population. Most of the variants are actually benign, including the one that is here on this slide. This is from a reconstructed CTA, and it shows the left coronary artery arising from what appears to be a bicuspid aortic valve, and it has a retroaortic course. So from a right-sided cusp, and it has a retroaortic course, and going to its location, this is considered a benign variant. Okay, so in terms of coronaries, malignant varieties are mainly characterized by the coronaries that are originating from an opposite sinus, and they have interarterial course. This type of anomaly may be behind some of these sudden cardiac deaths in young patients, and they're preceded by exercise and, in particular, athletic activities. Less than 1% of incidents are related to right coronary coming from the left sinus, and 1 in 1,000 is left coronary from the right sinus. What is really behind a coronary course to be malignant? One is hypoplastic lumen of the coronary. The other one, which is very important, is intramural course of coronary, and that means that the coronary is embedded within the aortic valve, and it's compressed and slit-like, and also the length of that. So it's not as if might be thought that being between the two arteries, this is compressing the artery, but it's more of a nature of the structure and intramural course of that coronary artery. So here, this is a depiction of different variants. This is a normal variant, obviously. This is what is thought potentially being malignant, interarterial. We can see that the left is originating from a right cusp, and it courses between the two arteries, and it's compressed. However, we have some variants that are pretty benign, including retroaortic for left circumflex coronary artery, as it's shown here, anterior or pre-pulmonary, it's shown for the left, and also transeptal or subpulmonary course of the coronary artery. Now, one of the helpful sequences on a cardiac MRI is 3D whole heart sequence, and that is with respiratory navigator. So it is taken over a long period of time, let's say 5 minutes. But since it's navigated with respiratory motion and it's also ECG gated, eventually it can be reconstructed in a very nice 3D view of the heart and the coronary vessels, or it can be used for other large vessels in the chest, including thoracic aorta. It's free breathing, radiation-free, and it's one of the perfect sequences for young children and infants in cases of congenital heart diseases. Otherwise, MR and MRA are really largely superseded by coronary CTA because it's faster and cheaper and gives better a view of the coronaries. This is a case of a transeptal or subpulmonic coronary artery. We can see that there is a right common origin, gives out the right coronary and the left. And the left has a course through the septum, as we can see on a reconstructed double oblique sagittal, that it moves under the pulmonary artery and within the septum. What is the difference between interarterial and transeptal variants? In transeptal, coronary is within a myocardium. It takes a downward course, as it's called hammock sign, like this we can hear, and it's not a lot of times oblong or slit-like. However, interarterial, the coronary is embedded within fat. It doesn't have a downward course, and it can be oblong or slit-like in appearance with narrowing of the lumen. We have another example of an aberrant coronary artery. It is basically originating from the right side, going to the left side, the left coronary artery, and it is embedded within the myocardium. However, in this one, we can see that there are areas of severe stenosis within the course of mid to distal LAD. So in comparison to that, we have the interarterial course when we have a common coronary artery from a left-sided cusp, and then the right moves between the two arteries, appears to be intramural and it's slit-like and narrow. And this would potentially be a malignant course. Okay, so the first case is a patient who was referred for cardiac MRI to evaluate anomalous right coronary artery. What sequences may be helpful and which sequences may not be quite helpful? I have included a VIBE, post-contrast T1-based VIBE sequence axial from the chest. And if you look here, you barely can see the origin of the right coronary artery. You cannot see the course of it. This has thick slices with a lot of distance between them and low resolution. So in this case, the VIBE is not helpful. However, the same patient has a 3D whole heart technique that shows the course of the coronary artery, right coronary artery. It's coming from the left cusp and has an arterial course. And in this patient, the 3D whole heart technique is more helpful to evaluate. Other sequences that can be used are stenase and small field of view. And it needs a little bit of maneuver, meaning that we can sit with the technologists, we can locate the coronaries, we can focus on them and try to demonstrate their course and action through cine images. And obviously, here we can see that the right coronary artery, anomalous right, and it's coming basically between the two vessels, and you can follow the course of it on small field of view stenosis. So these can be helpful. Here you can see the left coronary coming from the left cusp a little bit higher than what it usually comes. So the same patient has a CTA, and we can see that CTA is obviously a gated CTA. Coronary CTA would be a more precise way of looking at the anatomy. All right, this patient was sent for cardiac MRI for atrial fibrillation, pre-ablation, so completely irrelevant to coronary artery. From the get-go, when we did the fist, axial fist, it looks like there is a structure that does not really belong. It has a retroaortic course, looks kind of unusual in its appearance. And then later on, when we were doing the study, we tried to get a little bit more focus using the small field of view stenosis, and it turned out to be basically an anomalous left circumflex coronary artery coming from the right and having a retroaortic course. And as we talked about, this is a completely benign finding. So at times, we just incidentally pick up an anomalous coronary artery on a study that is done for a different purpose. All right. In terms of congenital heart diseases, there are a lot of helpful sequences that can be obtained. For instance, we have a 30-year-old male with possible double outlet RV and other anomalies. This is a T1 base Y sequence, but it's done with very thin slices and high resolution. It really nicely shows the abnormal course of the coronary artery. So we have what it appears to be a bicuspid aortic valve, and the anterior valve gives rise to two coronary arteries with separate orifices, one of which goes to the right and one of them is going to the left. And they appear patent and of appropriate lumen size. Same patient, an MRA with contrast was performed. At times, MRA may not be helpful, but at times it can be helpful. This was nicely reconstructed with multiplanar reformation, MPR, and again, we can see both right and left coronary arteries coming from an anterior cusp. So these two can be helpful if they're done with high resolution and smaller slice thickness. This is one of my favorite cases, and we had similar case scenarios in the past few years. This lady, younger lady, she came to the hospital with chest pain, and she had troponin rise and basically a non-STMI presentation. She initially was sent for a coronary CTA. The coronary CTA revealed anomalous origin of the right coronary artery from the left cusp with an interarterial course. However, did not quite explain the findings, the very acute nature out of the blue of the disease, and she had some other symptoms associated, which made it unlikely to be a resultant of an aberrant or anomalous coronary artery. So very rightfully, the patient was sent for a cardiac MR. So here on the left-hand side, we have the fifth sequence axial, and despite that this is not high resolution, you still can get an idea that the anomalous right coronary artery is there, and I especially focused on this one, and you can see it. The other one is the small field of view, again, shows the anomalous course of the right coronary artery. So these are all sequences that can be helpful. We went ahead and we did the whole heart, just for documentation, though we knew the answer. However, when we did the post-contrast to see if we can find, let's say, an infarction in the course of the right coronary artery, we found something completely different, which showed that we were right about the anomalous coronary artery not being the cause of her non-STEMI, but it turned out to be epicardially based enhancement of the apical lateral wall in a completely different region of the heart that we expected to see, and turned out to be a myocarditis. So, though somebody can have seemingly something that is a malignant course, she can have symptoms, cardiac symptoms from a different etiology. We have a case of a 25-year-old male. This patient had basically truncates and then transposition of great arteries. Sorry, he was status post arterial switch operation. In arterial switch, as you know, they do button transfer of the coronary arteries, and he had known ostial left main stenosis. This patient comes back for follow-ups once in a while to check on the status of his repair. He had a CTA done years ago that showed the stenotic origin of the retransplanted left main coronary artery. But the right coronary artery appears to be normal in its size and the lumen caliber. He also had MRI for follow-up on the status, and this is again 3D whole heart and shows the same finding. Does not appear that has changed. It's still stenotic, and although patient appears to be asymptomatic from that standpoint. So in terms of iatrogenic stenosis of the coronary arteries, we can use the common sequences of cardiac MR, and this is showing SNA, small fold of view, both of which show the reimplanted right coronary artery, which is patent, and this one is showing the left, which is stenotic. Another case of iatrogenic stenosis, 40-year-old lady, and she had an anomalous origin of left coronary from pulmonary artery, also known as L-kappa, and she was asymptomatic, came to VCU to establish care from an outside facility, and denied having any problems. As per notes in the chart, she exercises, no shortness of breath. I have included, this is a different patient. This is ETA, which shows a case of L-kappa. So we have the left coronary basically coming from the main pulmonary artery, and needs to be basically transferred to the aorta. So this lady who came from outside to establish care, she got her first MR. It was ordered as a stress test, and interesting enough, she had a pretty positive stress test in terms of perfusion defects. So we see a large area of perfusion defects, both the anterior wall and the septal wall. I didn't include all of the sequences. However, you could see the perfusion abnormality extending all the way from the basal to apical segment.
Vasodilator?
This was adenosine.
Oh, okay.
On the same exam, in an attempt to demonstrate the coronary arteries better, a 3D whole heart was performed. And it looks like at least the transfer happened in the right location, though it's difficult to evaluate the origin. Here, a patient was referred for a coronary CTA, and we can see that the origin of the left coronary artery is stenotic, it's narrowed, and slit-like, and this is what is contributing to the positive stress test. So she's still denied being symptomatic, so she's being considered for, excuse me, extra testing for evaluation of that. So let's switch the topics and look at some of the cardiac masses and their potential interaction with coronary arteries. This is a patient who has no lymphoma, an abnormal PET scan, which raised the question of cardiac involvement and metastatic involvement of the heart with lymphoma. On the left-hand side, we see the PET scan, an axial view, and this is an area of hypermetabolic activity. Looks like it's close to the atrioventricular groove, and we see a little calcification of the right coronary artery, so it's pretty close to the right coronary artery. The patient was referred for a cardiac MR. On the left-hand side, we have the Hayes sequence. We have an infiltrative process filling the arterioventricular groove. It looks like it extends all the way to the upper part of the right atrium and behind the aortic root. The right coronary artery is encased by this process. It is stretched and somewhat displaced in its location. Patient had very significant arrhythmia. However, the best attempt was made to obtain some images. These are the post-contrast, post-gadolinium sequences. We see the mass. It's not really enhancing, or it's mildly enhancing heterogeneously. It's in the same location we talked about. And then we have the basically coronary artery is present here. So if you remember from Dr. Harmati's lecture on cardiac tumors, and particularly with lymphoma encasing the coronaries, the question and concern is that whether or not to proceed with treatment, or is there a chance that this can swell up or start showing changes that can suffocate the coronary. But for most instances, they have to treat it. Lymphoma cannot be left treated, including this lady received treatment. And you can see in a very short period of time, actually, we have that area now without metabolic activity on PET scan, and also nothing in terms of adverse cardiovascular events happened for the patient. There is another patient, 58-year-old male, and history of non-Hodgkin lymphoma. I don't have an MR for this patient. There are CTs, just to show the importance of paying attention on a non-gated, regular routine CT, which is done for follow-up of lymphoma or other tumors and malignancies that can potentially metastasize to heart. So this was the initial staging. This is a non-gated study, shows pulsation artifact. And if we pay attention on the follow-up CT, we have, which was done after a few months, patient came back with disease recurrence. You see there is an infiltrative process within the arterioventricular groove, and it's encasing the right coronary artery. Although this is very difficult to pick up, one has to be aware of it. The patient happened to have a PET scan at the same time. We should not forget that because of inert activity of blood pool on PET scan, occasionally these things can be dismissed. But this was the same location, and it was cardiac metastases from the lymphoma with encasement of the right coronary artery. Again, the patient received treatment. However, I believe this patient passed. what about benign tumors? This is a 36-year-old lady at the first presentation. Cardiac tumor was detected on echo, which ended up in performing a cardiac MR. This is an MR from outside. This is a T2 fat SAT sequence. We see a lobulated mass-like lesion, again with arterioventricular grooves. It is encasing the coronary and displacing it. There were other sequences on the same MR. We'll go over that, but a PET scan, which was done at the same time, did not show any hypermetabolic activity in that area. Still was considered benign versus malignant tumor. However, on further follow-up, there was not much of change in the size of tumor for a long period of time. These are the perfusion sequences. They can potentially help to reassure enhancement, at least, of the coronary artery and perfusion of it. So here we have the mass, which is pressing on the right atrium, somewhat involving the tricuspid valve, encasing the right coronary artery. We can see that at least the proximal right coronary artery is filling with blood during the first pass perfusion. Same one on axial view, tumor not enhanced initially, later on shows a little bit of enhancement. It's not a hypervascular tumor, and it's encasing the coronary, which shows some enhancement. These are the delayed post-gadolinium sequences. I have outlined a region of tumor, which shows kind of nodular internal enhancement. Upon biopsy, it turned out to be a vascular tumor, did not cause any problem for the patient. However, to make sure that the coronary, which is encased by tumor, is patent, a CTA was requested. So the right coronary artery appears patent of appropriate human size. And these are reconstructions made by Dr. Wizard. I really like these reconstructions, and you can follow the coronary artery all the way through that tumor here. And you can see that though displaced, it remains patent. This is another case. I believe we presented this years ago as a case, but this gentleman came to the hospital and he had acute MI. And he underwent an echocardiogram which showed an abnormal structure in the heart. So we have the apical four-chamber view here. And this was the abnormal structure. It's peripherally echogenic and centrally hypoechoic. And it's an elongated structure somewhere between the right ventricle and the right atrium. Patient was referred for an MRI. On the initial Steni sequence, we described a kind of lobulated oblong mass-like lesion. It is in the course of the coronary artery. We see the right coronary cusp and the right coronary artery as if it seems like it's entering this structure, and the structure continues in the course that the right coronary must be. It has a heterogeneous hyposignal. The post-contrast shows that structure to be not initially enhancing. And at the same time, we can see that there is a large MI. It's involving both right and left ventricular, inferior wall, base to apex, with a large hyposignal structure here, which is basically the macrovascular obstruction or no reflow zone in context of acute MI. So what is this structure? This is basically an aneurysmal right coronary artery. Again, on the delayed gadolinium enhancement sequence, we have transmural enhancement of the wall and a large, basically, MVO or area of no reflow. So these aneurysms are known as giant coronary aneurysms. Either they are 4 times larger than what they should be, or they are over 8 millimeters in diameter. That's when we call them giant. Atherosclerosis accounts for majority of coronary aneurysms in adults, but Kawasaki disease and later on COVID inflammatory syndrome are responsible for cases in children. 1/3 of this can be associated with MI, obstruction, arrhythmia, and sudden cardiac death that unfortunately that patient did not survive. Another case, this is a 32-year-old female. She came to ED one time with chest pain, and they went ahead and they did a PE study. Now, you can see that on the CT-PE, you have very good enhancement of the pulmonary artery as it's supposed to be, but with that little bit to no enhancement of the arterial system, you can imagine there is a kind of rounded structure associated with where the bifurcation of left main into the left anterior and left circumflex coronary should be. So upon questioning, actually, she explains to the providers that as a child, she had Kawasaki disease. And this is a known aneurysm that she has had for many years. After that, she actually stayed with VCU, established care here. Every few years, she comes back, and we do cardiac MR for her, cardiac MRA, with 3D whole heart to check on her aneurysm. So on small field of view CNA, the aneurysm can be seen as a focal dilatation of the coronary artery. And this is her 3D whole heart. So it's not just the left side that has the aneurysm, but the right side also shows an aneurysmal dilatation. Over this past few years that I had seen her studies, they all remain stable in size and does not cause any problem for the patient. All right. So this basically MRA and cardiac MR for patients such as this lady who have aneurysms that they don't need to repair, but follow-up is a very appropriate study because it mainly preserves them from extra radiation. This is another gentleman came with chest pain, abnormal echocardiogram, and sent for cardiac MR. This is one of the studies I really like. However, I wished we could get some more information on this patient. Was followed years back. Some data is available with CMR. I could not retrieve it, so I basically based my claim on speculations and looking at different studies. So the abnormality, these look like earrings here, are basically very thickened coronary arteries. And if you look on, so these are the two fifth NAs, we have a very tortuous, lobulated course of all the major coronaries. And they're all thick-walled. As you can see, the little lumen of the coronary appears as an area of high signal in between a very thick area of low signal. Patient had renal disease at the time the study was ordered as non-contrast, so we don't have a post-contrast to see how these look like. However, after that, patient was referred for coronary CTA. So here, this is his initial CT, and we can see this big fold. There is accelerated calcification of the coronaries, and with wall thickening. But unfortunately, over time, all these coronaries started becoming pretty aneurysmal. The lumen showed aneurysmal dilatation and kind of a beaded appearance, and eventually patient succumbed to his illness. After looking at this and comparing it to some other studies, it appears to be some form of vasculitis, and mainly the one that I was thinking about is IgG4 related disease. It's a systemic inflammatory disease. It's marked by elevation of serum IgG4. Has to be confirmed by biopsy, and also elevated serum IgG4. So we have on path, we have fibrosclerosis, lymphatic infiltration, we have IgG4 positive plasma cells. It responds pretty well to steroid and immunosuppression. Cardiovascular involvement happens. It can appear as pseudotumors of the heart, also inflammatory periaortitis, and coronary arteritis, and pericarditis. So how does MRI in general help in terms of vasculitis? It has a complementary role compared to other studies such as CT and PET scan, but it can be helpful. One is black blood pulse sequence, or T2 in any form, fat saturated and non-fat saturated, which shows edema within the valve. Such as we can see on the haze, we have low signal surrounding the coronary artery that shows that there was some component of edema within the vessel wall. Well, obviously, delayed gadolinium can help with inflammation, fibrosis, scar, and with MR angiography, we can have a general look at the vessels. It's very important to determine what size vessel is involved, because it can there is a variation from one type of vasculitis to the other one in what vessel size is involved. It's an alternative assessment of coronary arteries, especially for pediatric patients. In some studies or some institutions, DWI has been used, and also dynamic contrast enhancement MRI. This was an interesting case of a 23-year-old male, and he came to emergency department following high-speed MVC, and so this is an initial MRCT. Patients intoxicated, there's a lot of motion, and also pulsation artifact. This is not a gated study, but interestingly, out of expectation, and we come up with a lot of interesting incidental findings in trauma patients who come literally off of the street. They're very large, rope-shaped, diffusely aneurysmal coronary arteries. We see a tangle of vessels in the subcardiac region. So it was advised that patient receives a gated CTA when he's stabilized, which happens basically. This is CTA was done by Dr. Dana, and we can see the tortuous and diffusely dilated coronary arteries, and interestingly, we could establish a fistulous connection between the left circumflex and between the left ventricular cavity, which makes this a coronary cameral fistula. Now the topic of fistula, coronary fistula, is very wide. MR can be helpful in that. As you can see here, we have basically an MRA, and it shows basically this is the 3D whole heart, and we see the tortuous vasculature, and here the same thing, we see the abnormal communication with the left ventricular cavity as the coronary cameral fistula. All right, so this patient has a systemic disease, and he was referred for assessment of constrictive pericarditis. This is a CT, very abnormal looking. Looks like we have tremendous infiltration of the epicardial and pericardial spaces with some sort of hypodense soft tissue. We can also imagine that the pericardium is all thickened. This also encases the coronary arteries. However, the coronary arteries appear to be patent, at least to some extent. There is an image of the abdomen here. We have the same abnormal infiltration within the liver around the portal veins. And interestingly, we have a lot of infiltration around the kidneys, and kidneys appear to be shrunken from this infiltration of capsule, which pushes on the cortex. So this is a case of Erdheim-Chester disease. So Erdheim-Chester is a rare non-Langerhans, non-familial mite-like systemic histiocytosis. It has a widespread manifestation. It can be okayish to highly severe in appearance of it. Heart is involved in 40 to 70% of the cases. So this is a case of Erdheim-Chester. This is the fifth sequence and shows extensive infiltration around the heart. Appears to be hypo signal or hypo intense on the sequence. So here again, we see that the heart is pretty all around it infiltrated. We have thickening of the pericardium, appears to have a little bit of pericardial effusion, and we have very wide, vast infiltration and encasement of the coronary arteries. We also have pleural effusions and involvement of the lung. Many images in 2-chamber and 4-chamber views, the same. Although it looks like the EF may not be so bad and the wall motion is not that declined, we still have septal bounce and tubulation of the ventricles, which tell us that there is a component of constriction here done by the infiltration and by the pericardial involvement. Here, there are T2 non-fat sequences, shows that some of the infiltration is hypodense and some of hypointense, and some of it is hyperintense. Right. So the same patient has a rest perfusion, and we see that the soft tissue does not enhance, at least immediately. So what can happen if we have cardiovascular involvement? Patient can be asymptomatic, but there is an array of symptoms that can happen, including arrhythmias, involvement of valves, ischemia, heart failure, hypertension. And hypertension, sometimes they blame it on kidney involvement and not really the involvement of the heart. And myocardial infiltration. So periarterial infiltration of the coronaries can happen in Erdheim-Chester, and it can cause vascular stenosis and territorial ischemia in some cases. It's the same patient. This is the wide sequence, and we see involvement of the heart, some of it enhancement, but majority is not. Also, we have enhancement of the pericardium. Look at the lungs, you see very significant septal thickening, one of the other findings of airtime tester. We also see that there is edema in the chest wall and soft tissue. Excuse me again. Now on the delayed post-gadolinium sequence, we have now enhancement in all areas. This is the pericardium, which is thickened, and we have a little bit of effusion within the pericardium. Thank you so much for your attention.
Well, great. Thank you so much, Dr. Rezai. That was a really wonderful overview. I came up with a couple questions if people are thinking of their questions too. Whoops, let me bring it back to the CME slide. So, you know, going back to the anomalous coronary artery takeoffs, and you mentioned a lot of features that can make them malignant as opposed to benign, like the slit-like orifice, you know, intramural course. But as you mentioned, a lot of what makes them dangerous or benign depends on, you know, the severity of that or how much of the length is affected by it. Did you come across any, you know, attempts to sort of quantify that or come up with some kind of scoring system so that we, you know, like, is there a certain length of intramural course that should be concerning, or any amount, or, you know, has anyone gotten into that sort of space?
Not that I know of. There might be. I'm not aware of any, if there is any kind of grading system. I don't. So we come across a lot of anomalous coronary arteries in elderly patients, which are incidentally deep, and you can imagine that patient has lived with this for years. I assume that those who show up with ischemic signs and symptoms, and hopefully not that a severe arrhythmia or something like that, I assume those are the ones who receive treatment. Now I see a lot of things being observed and seem to be doing okay. I guess patients' lifestyle is also an important factor in how they're being treated. But if there is a grading system, I'm not aware of.
It's a very tough thing, you know, to have a conversation with the patient who feels otherwise fine and sent for surgery based on imaging findings alone, you know, that were otherwise incidental a lot of times. So it's kind of a tough situation for the patients oftentimes.
No, I can imagine.
Anybody else have any questions from the audience? All right. Well, thanks again, Dr. Rezai, for that wonderful talk. We're going to take a hiatus from the conference for the next couple weeks during the winter holiday. So hope everybody has a nice winter break, especially if you're traveling. And we'll see everybody back in the new year.
Great talk, Leila. Thank you.
Thank you.